Okay. Now my paper is on simple limbal epithelial transplantation, that is SLET, the comparisons of outcomes of two different techniques. So we all know that SLET was first described by Sangwan et al. In 2012, and it was been found that with currently used surgical techniques for management of LSCD, that is limbal stem cell deficiency, SLET seems to be a safe, reproducible, and effective alternative. So in classical SLET, a small donor limbal graft from the unaffected eye is harvested and divided into smaller pieces that are then expanded in vivo in the stem cell deficient eye over the human amniotic membrane using fibrin glue. Now in 2014, Amiska et al. First described this modification of this technique where two amniotic membrane layers were used to sandwich and protect the harvested limbal stem cells. So this is the schematic representations. This is a limbal deficient eye where there is symblepharon. So first we have to release the symblepharon and then go for this 360-degree congenital peritomy, and then put the amniotic membrane graft and then take the limbal transplants from the other eye and then put it over the amniotic membrane graft and then put a bandage contact lens. In modified SLET, where we have to put another piece of amniotic membrane and then suture it by tenonylon circumferential for string suture. So the purpose of this study is to compare the long-term clinical outcomes of two variants of autologous SLET, that is C-SLET and M-SLET, for treating cases of unilateral LSCD. This was a single-center prospective comparative interventional case series in our institute from June 2014 to August 2019 by the presenting author. So there were 27 cases of SLET, out of which 12 cases underwent C-SLET and M-SLET had 15 cases. So these are the etiologies, and most of the cases are because of alkali injuries. And children were having 9 cases and adults are having 18 cases, and in all children underwent this M-SLET techniques. Partial LSCD and total LSCD. Partial LSCD was found in 7 cases, where this is all partial LSCD cases also underwent only C-SLET, classical SLET. And total LSCD cases out of 20, that means 13 cases underwent this M-SLET. So main outcome measures were that follow-up ranged from 1 to 4.5 years and with a median of 1.6 years. And the success of SLET was considered when the recipient eye was completely epithelialized with vascular cornea. And failure was defined as the recurrence of the progressive conjunctivalization onto the central 8 mm with or without persistent epithelial defect. So this is the diagram where this out of 12 cases of C-SLET, 8 had successful results and 12 in cases of M-SLET have successful results. And if you look at the survival rate, these C-SLETs are having 66%, 66.6% of the survival rate, and whereas in M-SLET it is 80% cases. So just going to the statistical analysis, a stable ocular surface, that is successful outcome, were seen in 20 out of 27 eyes with a confidence interval of 74.047 with a range of 57.54 to 9.6%. Failure was found in 4 cases of C-SLET, that is 33.3%, and 3 cases of M-SLET, that is 20% cases. Since 74.07 is a more than threshold value, it is claimed that SLET is indeed successful. And from the binomial proportion test for equality of the success rates, in these two types of SLET, the G-score was obtained is 0.73, which leads to the corresponding p-value of 0.2147. This provides definite support for the fact that the difference in success rates of M-SLET and C-SLET is significantly larger than 0, or in other words, the success rate of M-SLET is larger than that of C-SLET. However, in order to perform a more informative test, for example, a test of 10% significance level with more observations are needed in future. This is the phases of risk of failure. It is found that thermal injuries had worse prognosis, and patients with pre-existing symblepharon in both the lids extending onto the cornea had very poor prognosis for recurrence, that is 4 out of 5 cases, 80% of the cases. In C-SLET, 2 patients had postoperative loss of transplants and 1 needed repeat surgery. This is the patient who lost these transplants and then repeat surgery, and this is the result. Still not very good. So in M-SLET, double AMG was used as a modification to protect and secure the limbal transplants. This procedure is quite easy and can be replicated by most of the ophthalmic surgeons. The ideal candidate for M-SLET are children with unilateral LSCD with wet ocular surface, where the chance of loss of transplants because of accidental rubbing are quite high, and in patients with symblepharon. Our strength of this study was that this is having this longest follow-up, but in modified SLET technique by Amiska et al., they had only less than 1 year follow-up, but out of 4 patients, 4 had very good results. So this is another study of modification by Chinese authors, where they have put this neurons in, directly onto the stone, and they found that quite good effect. So to conclude, the results of both the technique of SLET are effective and promising for the management of unilateral elasticity and seem to be safe and reproducible. In MSLET, the use of so-called sandwich technique provided protective environment for the graft and the limbal stem cell niche without compromising the clinical outcome. The long-lasting corneal regeneration is significantly better in MSLET than CSLET, and MSLET should be practiced especially in children. So the pitfall of the study was that this was non-randomized. Limbal stem cell deficiency was diagnosed, and post-SLET patients were evaluated clinically without confocal microscopy or impression cytologic analysis. These are my references, and thank you for time.
Thank you so much. I request the judges, if they have any question, they may shoot.
Good presentation.
Go ahead, Dr. Deepshika.
Nice, please.
Yeah, actually, I was wondering, what is your post SLET treatment schedule, or how long do you give steroids for?
Usually, we give in tapering dosage for only just topical steroids, no oral steroids. Oral steroids are given only those patients with AIOC2021. But here it is this auto SLET, so we are giving only topical steroids, that is 6 weeks in tapering dosage. Usually dexamethasone is initially 4 times, then 3 times, then 2 times, then 1 time, like that way. If the inflammation is severe, then we can go for 6 times also.
So you're using for 6 weeks. 6 weeks.
Yeah.
After 6 weeks, you stop, treatment?
Stop it, and then we see that whether there is this. In some cases where there is inflammation is persisting, we can give some sort of cyclosporin or anything like that, but no steroids, because these patients are having tendency to develop steroid responsiveness and then can develop glaucoma also.
Okay.
All right, I'd like to request Dr. Pradeep Pant. Has he already joined us?
Yeah, sorry, madam, little late, but fine.
It's okay,
no
sir.
I was not getting.
I'd like to introduce you to one of our convener, Dr. Pradeep Pant, ladies and gentlemen. And moving on to the next presenter, please.
Can I ask one question, madam, please?
Yes, please go ahead.
See, how long is the follow-up?
2 minutes.
How long you do the follow-up?
So for these patients, whoever is having less than 1 year of follow-up, we just we didn't include in the study. Our follow-up ranged from that was 1 year to 4.5 years.